Hello, I'm Jeremy Fernandez and welcome to our weekly live stream to answer your questions about the coronavirus pandemic. As always, leave your questions in the comment sections below and we'll get to as many of them as possible. Now, joining us on the live stream this week is the infectious diseases physician and microbiologist, Peter Collignon from the ANU Medical School, and also GP Dr. Mukesh Haikerwal, who's the former head of the Australian Medical Association. Welcome to both of you.
Thank you.
Thank you.
Lots of questions this week on a week that's been very difficult for a lot of Australians, particularly in Victoria. Peter Collignon, I want to start with you about where you see this pandemic heading, particularly in Victoria, given the stunning figures we've seen out of that state in the last few days.
Well, I think in Victoria there's going to be quite a while to go. I mean, there's a lot of people that are infected and there's probably a lot of people we don't know yet. I mean, the numbers I've seen suggest that maybe 1 in 500 people already have been infected or are infected in Victoria, and, you know, that number could go up. I guess, you know, and that'll take quite a while to get those numbers down because people mainly transmit this indoors to their work colleagues, to their workmates, their friends, or inside to their family. So there's still probably a lot of people in those close contacts who may not have been infected yet, even, you know, when we've identified people as infected.
Dr. Haikerwal, what's your view about where Victoria is at this point in time?
Well, I'm afraid I would agree. The situation here is pretty dire. You know, to be put into a state of curfew from Sunday night, to have what's called stage 4 restrictions with us, to have workplaces shut down, shows very clearly how dire the situation is. And we've had many new regulations and rules cobbled together in a rush. Not very understandably, by the way. I understand it's a rush. We've just got to get this done. But we are seeing, as Peter has said, people from many different areas: childcare, aged care, working in offices, working in factories, working in distribution centres, working in healthcare, all different sorts of walks of life, coming back either themselves being tested positive or direct contacts of people who have been tested positive. So yes, the numbers are big, and we do need to keep testing these people, and we do need to make sure we get people into the right frame. You know, if they need to be quarantined, do that. If they just need to be watched, do that. But we need to get good information to them as well.
Dr. Haikerwal, what is it about the restrictions as they've rolled in gradually over the past few weeks that's not working, that's caused the numbers to stay at this level for such a prolonged period of time?
Well, I mean, I think that the review of some of the information and data suggests that if we hadn't done stage 3 weeks ago, and we hadn't gone into this latest lockdown on this, you know, Sunday just gone, we would be in a much worse position than we currently are. So what's happened is that we have seen this thing work. The difficulty, I think, is some people still aren't taking this thing seriously. We still see people, well, until last few days when we got the curfew happening, out and about. And I think we were seeing much more of a clampdown by police and the support services to make sure that people are where they should be, which is at home.
Peter Collignon, can I get your view on this question as well about why the numbers are at such a sustained high level despite the restrictions that have rolled in over the past few weeks?
Well, I think one of the problems is I think the basics haven't been done for a while, and that's the physical distancing, the hand hygiene, but particularly people who are unwell staying away from the workplace. And if you look at most of the outbreaks that have occurred where you've been able to follow them, there's been someone with an illness who's gone to work and infected others. And I think one of the other problems is we tend to think it's other people that have got this problem rather than us. But the reality is most of this spread is within households or with our work colleagues. In the hospitals, for instance, we tend to assume it's the patient. But a lot of the outbreaks have occurred with friends and colleagues, either in the workplace, in staff rooms or tea rooms, or at, you know, socialising with them. And even if you go back and look at the outbreak in Melbourne, yes, it was a leak from the security hotels or the quarantine hotels to the guards, but it was particularly them socialising with friends and family at home that then spread it. So I think we've got to do everything we can to, yes, you know, stop the transmission out in the community, but the most dangerous place is when we're inside with others, and particularly if they have symptoms. And that's not only people we don't know, It's people who are our family and friends. We've got to keep the distance even within our own homes, as well as workplaces, etc.
Professor Collignon, one of the most extraordinary things that's been taking place is the level of contact tracing, which is very difficult to get your head around, particularly when the numbers are so high. And there are still, despite that, quite a number of cases where the contact tracers just can't find the source of an outbreak. That must be a very big concern for you.
Well, it is a big concern, and particularly in Victoria, where the numbers are so big. In fact, to do contact tracing properly is quite difficult at this stage. But look in New South Wales, where they aren't overrun, but it's a very big undertaking if you look at there. Now, the only good news is, relatively speaking, the ones we're really worried about are the ones where we can't define a case, a cause or an association where they've really looked. And they're occurring about once a day in New South Wales. But for every one of them, there's another person because you haven't found where it came from. So they're the real risk. Now, in Victoria at the moment, one would hope with what restrictions are put in place, if people do the basics in their own home and workplace, including the essential workers, that will stop this transmission and get this R number below 1. In New South Wales, it's a different situation than other states where much more effort has to be put into all these contacts because there it hasn't gone out of control and hopefully it won't go out of control. And so Victoria, I think, is a different situation on how you need to approach it.
Professor, Dr. Haikerwal, we've got the situation at the moment where various states and territories are keeping their borders closed. Queensland closed its border with New South Wales and treats all of the ACT, New South Wales and Victoria now as a single hotspot. What is the risk in those states and territories outside of Victoria of this virus blowing out of control again?
I fear that despite closing the borders, there will be cases there. We didn't do anything spectacularly different in Victoria. I guess we had some more air traffic because most flights were diverted to Victoria, and then we had the issues with the quarantine hotels and so on. But my real worry is it will go to other states. And what we want to do in Victoria, what I want to see happen in Victoria, is that we nail this, we lock it down, we stop it from spreading. If we can stop it happening altogether and eliminate it, which is the big hope, and I don't know if we'll ever get there, but if we do, then other states won't get that. And if they do, there's a methodology that's tried and trusted for them to use. At the moment, we're just trying everything that we can to get this right. The Premier's been very strong, very forceful, quite rightly. Our Chief Health Officer has been remarkable in keeping his cool in this situation. And we're just doggedly going through this process. We're not helped, I think, by the way in which the bureaucracy is working in this process. They're not really generating a whole lot of trust within the people who've been tested positive. And they're certainly not working with the frontline healthcare workers, who, by the way, we haven't mentioned, but they're the biggest source of concern for increased levels of infection in our community. They're the ones on the front line looking after people, putting their lives at risk. And as a group, they are not being well looked after. They're not getting access to all the things that they should be getting in terms of protective care and so on. And they've often been given a bum steer. And I think it's really important that they come out very clearly and state they don't want to see any infections and injury and death within the health workforce, because we're already seeing a large number of people going down, and we expect to lose about 25% in the next few weeks, which means there'll be nobody to run the beds and to run the services if we're not careful.
There was an issue here particularly about the use of face masks, and I know the AMA has just released a statement demanding the mandated use of filter respirator masks for COVID-19 patient care. So those caring for patients who have COVID-19, at the moment they're using the N95 mask or the surgical mask, and that protects the patient, but the protection isn't so strong the other way.
Totally. We in our respiratory clinic, I've actually come out of a session to talk to you. That's why I'm dressed like this. I had my full gear on just now. I had a proper N95 respirator. I actually put a surgical mask on top of that, Peter, you'll be glad to know. And I put a visor on top of that, so minimizing contact. And, if you're working with people with COVID, you need to be protected because, it's, as Peter said, it's not that face-to-face necessarily that's the issue. It's your colleagues and people around you that can also do that. But you don't want to transmit and be infected in these situations. So, yes, N95s are absolutely vital for people on frontline service in this space. and any other benefits from additional things that are important too. And I think that AMA, I'm biased, I guess. I'm a former national president and state president, but absolutely, we're looking after our members and our colleagues that are working in the health sector who are absolutely putting their necks on the line here. And we want to make sure that they're safe. We don't want any infections. We don't want them to get the illness. We want them to stay well to be able to look after the community.
Professor Collignon, I want to bring you in on a question that creeps up for all of us who work on this program, for our viewers. We hear this remark over and over again. This is a disease that just really takes down old people, so why the overreaction? Now, I personally hear this several times a week. I know a lot of our viewers do as well, and that's significant in circumstances where this week we've seen people in younger age brackets not only being hit by COVID-19, but in some cases also dying. I want to know what your view is about this idea that COVID-19 is an old people's disease.
Well, it isn't just an old people's disease. Everybody can get this from the age of 0 up to the age of 110. What it does is it affects people differently. For instance, in data I did with another person a few months ago, looking at Australia during the first wave, if you're over the age of 80, your chance of dying from this is 15%. If you're under the age of 50, it's less than 0.1%. And you say, well, what's the deal here? But you've still got a risk of death even if you're 30 years old. But it just happens to be much lower. But the real problem is if you let this spread widely, say your death risk if you're age 35 is 1 in 1,000. You say, oh, should I worry about that? Well, first of all, you might die 1 in 1,000, but 10 times as many people will be sick in hospital. But if you have 100,000 people infected in that age group, at that death rate, that's 100 deaths. So that's a very high number of people who otherwise would not die of respiratory infections. And yeah, let's put this in perspective with influenza. Influenza also mainly kills people over the age of 80, but it can kill younger people. The difference with COVID, it does so at probably 10 or 20 times higher rate per person infected. Now, the only good news about this, compared to the Spanish flu of 1918, the big death rates were actually in the very young children and people in their 20s and 30s, particularly males. Now, luckily, that's not happening, but the big, all age groups can die from this. They do it at different rates, but if you have enough people get it, you'll have a number of deaths in age groups that you would not normally expect to see this.
Dr. Haikerwal, death rates are one way to measure the impact of COVID-19, and of course there is more and more evidence coming out about the impact on a person's health, even if they do survive COVID-19. Yeah.
Absolutely, that's exactly the point I was going to make when Peter was speaking. Very clearly, death is one part. We don't want to get there, obviously, but if somebody does get it, whether you're older or not so old, whether you're in your 30s or less, what we're seeing is the sequelae. What happens at the end of that is that you can have neurological problems, like you've had a stroke or some degree of epilepsy or some sort of neurological problem. You can certainly have heart problems where your heart no longer pumps as effectively and efficiently as you want it to. You can get skin problems, you can get other features. So it's not a simple thing like a cold you get in the winter. It's not like a flu, which actually kills people. And, as Peter was saying, we know that, for instance, pregnant women who get flu have a big problem. That's why we immunise them so much more now. This is worse than that. It's much more infective. And the actual problems at the end of it are really quite dramatic. And many haven't been actually enumerated. We don't know what the things are in the future. In fact, we don't know the outcome on a pregnant woman who might be catching this very early in the pregnancy later on. We don't want another Zika kind of situation where all of a sudden a virus comes up and later on down the track you realise how dreadful it is.
Dr. Haikerwal, Lisa Davis has this question about what the rate of false negatives are, and someone else asked a question as well about if false negatives are a significant factor here. Should people be compulsorily tested sort of every few days until they can absolutely definitely be cleared?
Yeah, the technical side, I think Peter's well equipped to talk about that. But from my point of view, the issue is that when we do the testing, we do know that there's a false positive level. And so when we do a test, we don't say to people, just go for your life as soon as your result comes back negative. We're actually saying you can allow a couple of days from when your symptoms started until you've got your negative test and make sure your symptom clear before you stop isolating. So it's a bit more than that because your symptoms can develop in that time. Compulsory testing a whole lot of people over and over again may be useless because we know they're going to be positive and stay positive for quite some time after. Our department guidelines say that 14 days from your symptoms starting, you're deemed to be clear, even though you may not be clear. And actually, I'd be very interested in Peter's point of view about that, whether 14 days is a safe period.
Peter Collignon?
Well, first of all, we do get false negatives and false positives. The main test we use is called a PCR test, which detects the virus in our nose, throat, etc. And it's a very good test. You don't get many false positives. There's some, but they're very uncommon. The false negatives are an issue because early on when you're incubating the disease, you may be asymptomatic and you may have no virus, but tomorrow it's positive because it's a day before you develop symptoms. So we've got to be careful about saying a negative test means you can't get it. The obvious people who need to be tested is anybody with symptoms, because if you have symptoms and you've got COVID, there is a very high probability you'll have a positive test. I don't think there's much value in taking random people without symptoms and testing them because you're very unlikely to get a positive test. And unless you're doing some survey of 10,000 people to see who might have it asymptomatically, it's a waste of time. Who is worthwhile testing asymptomatically is high prevalence people. In other words, return travellers. We know a few % of them are positive, and therefore I think it is a very good idea that they're tested on day 3 and day 10. Now, how long you're positive for is another issue. A study from South Korea shows you can be positive even up to 60 days after your initial positivity and that you appear to be normal because there's trace amounts of the virus still in your throat and nose. But it didn't appear, at least after about 28 days, that any of these people still were infectious to others. So how long you actually keep people away from work and from others after a positive test, I don't think we know the answer. But I would think probably at least a couple of weeks after you have a positive test and also not having any symptoms for quite a few days. I think that one of the trouble is I heard somebody went back to work because they had a positive test today. They'd already been sick for a week and they said, after 3 days, no symptoms, go back to work. I think we need to take that longer because there's still a lot of unknowns. I would think, after you've dropped your symptoms, you ought to still assume you're infectious for at least a week and probably a couple of weeks.
Professor Collignon, there's been a really stunning take-up of face masks, I know, particularly in New South Wales, Victoria and Queensland, where the virus has been circulating. And at the same time, we've got a number of questions from viewers about how face masks are used. So the handling of face masks, whether they're fitted correctly, whether it's the correct face masks for the context, depending on how close and how prolonged the contact with another person is. Do you have a view? I mean, some people are suggesting that maybe this sort of thing should be policed, the use of face masks. What's your view on the take-up of face masks and how they're used in the community right now?
Well, I think the value of face masks, I think as the Chief Health Officer of New South Wales said, remember it's, 4th or 5th line of defence. The first ones are washing your hands, physically distancing from anybody all the time, but particularly people who are sick, etc., not going to work. So face masks have a value. Mainly, if you've got a face mask on, if I've got COVID and I cough or splutter, it stays more confined to my face. So if I then don't propel those droplets out onto everybody for another metre or 2 metres. So but that also means you've got to get a lot of people to wear it. And it also means their main value is when you've got a lot of transmission. So in New South Wales, I think the current advice, which I don't disagree with because there's still a low prevalence there, if you're in a situation where you can't physical distance, wear a mask, because I think that gives you some protection, cloth masks and surgical masks, as well as much more protecting others. So I think that's a very good idea. Public transport, even in the workplace. The other thing that protects you a fair bit is face shields. Which are reusable by a person, for a week or two, because it means if I cough or splutter, it goes on the inside. If somebody coughs or splutters over me, it goes on the outside. And also when I try and touch my face, I hit that because we all do that subconsciously. So I don't inoculate my eyes or nose, etc., with virus I might have in my fingers. But what type of mask you have and where you wear them, surgical masks are slightly better than cloth masks, at least at stopping influenza, based on one study. There's probably not a difference between these N95 masks and P2 masks, particularly in the ordinary community, because most spread is via droplets. And that actually means surgical masks are as good as P2, P95 masks. And some of those type of masks In fact, if they've got expiratory valves in there to make it easier to wear, in fact, are a risk to others because there's nothing to sort of filter the virus when somebody who's got it who exhales it. So, and even in the medical situation, I know this is controversial, but there's not much evidence that aerosols are a big part of it, which is good news because if aerosols were, they stay in the air for hours and we can breathe them in and they go deep into our lungs. It'd mean we couldn't have a restaurant or anything open for the next 3 years till we get a vaccine because every time you took the mask off, you'd run the risk that you inhale and get it. So the good news is that most spread is via droplets. That means face protection, eye protection, surgical masks, cloth masks, give everybody a lot of protection. And if people are wearing them, if they've got it and they're still subclinical or haven't got symptoms yet, they will give it to less other people as well.
Dr. Mukesh, Haikerwal, is part of the problem here that the messaging on face masks has been so difficult to get out in a coherent way since the start of the pandemic?
Yeah, look, at the very beginning of the pandemic, late January, I suppose, starting February, if people were seen with masks, they were decried. Why are you doing that? You need to save this for the health workers. It was keep your distance, keep your hands washed, and so on. I think what we've seen in Victoria, it was absolutely necessary. It's actually really good to see people using them. At our medical clinic, at our respiratory clinic, people are all wearing them as they're coming in, and they see the benefits in doing that. Very little pushback, I believe, much less than I was expecting. You got the odd, person looking for a little bit of fame doing this, but in general, people are doing the right thing. My comments about this in the clinical workplace are slightly different. I mean, I know things are controversial around the droplet spread. That's absolutely unrefuted, but the aerosol stuff is gaining some momentum. And I think that we need to be wary of that. If there is one less risk we can mitigate, let's mitigate the risk. And that's why, certainly in the clinical setting where you're face-to-face with people all the time, we should be wearing N95s, I believe, in the clinical workplace.
Peter Collignon, I want to pick up on your point about droplet spread. We get this question every single week, quite a few times. What is the risk posed by surfaces that are contaminated?
Well, I'm a big hand hygiene advocate for lots of things, including MRSA and lots of bacteria. But relatively speaking, the biggest risk is being close to somebody and them either fluttering their saliva over you or coughing or sneezing on you. So it's the physical distancing and the protection against droplets. However, I think hands can be a vehicle as well, less important than that. But, I don't see any harm in assuming that hands can be a vehicle because we touch ourselves frequently. And for other respiratory infections, we know they are means of transmitting it. So I think the basics that we've been pushing all this time is keep your distance, keep away from people who are sick. If you're sick, keep away from them. Wash your hands with either soap and water or alcohol hand rub. All of those things give you a huge level of protection. And the really important thing is we want to get this reproduction factor below 1. In other words, we want 10 people to give it to 6 people to give it to 4 people, not 10 to 14 to 16. Otherwise, we have an increasing epidemic. And if we do all those things, and not only with strangers, but do it in our own home as well as much as possible, that gets the R number below 1.
Yeah. Can I add as well, Jeremy, on the mask issue? I think you mentioned this previously, is how you deal with it's really important. So if you're going to take your mask off, you should actually wash your hands first, then take it off by the sides, not from the front, because once you touch the front, you've actually defeated the object of having the mask there, which is keeping the front clean. So you take the mask off that way and dispose it properly in proper disposable containers out the way. If it's a cloth one, put it into a bag so that it can be properly washed. And when you put it back on, be careful how you do that. So if you're touching the front of the mask and you've done that, you then wash your hands again before you do the next job, because you're now out of your contaminated area. So mask care is really important, very important if you're doing it properly. Otherwise, if you touch it after you've been wearing it, you've done the right thing while you're wearing it, all of a sudden you've defeated the object.
Professor Collignon,
look, I fully agree.
Yeah, go ahead, sorry.
I was going to say I fully agree. Part of wearing a mask properly is to look after your hands as well, so you don't contaminate your hands with the outside of the mask and virus that might be there, and then get yourself an infection that way.
I want to come to a question that Lisa Davis has just posted, a really good one. Has the virus mutated in a way that makes it more or less dangerous? You hear theories about this, that as the virus sort of continues spreading, it becomes weaker or it becomes stronger. Peter Collignon, do you have any intelligence on that?
Well, I think the short answer is we don't know for sure, but I don't think there's good evidence that it has become either stronger or weaker or spreads more readily. I think one of the reasons we see this discrepancy, in a lot of countries they've been so overwhelmed that they really look like they've got high death rates because they just don't test the people with mild illness because they just can't get to them. So a lot of countries with high death rates, and then they improve, and the US was putting up this argument. It's because they were so overwhelmed and had so few tests a few months ago compared to now. Their death rate has come down, but only because they're picking up more cases. So Australia is actually, well, so far, been in a pretty good place to check the death rate and the spread. And the main factor is your age. And I don't think we've got really good evidence that there's much difference. The death rate is much higher than I was originally expecting. I thought this would be, a death rate about 0.3%. I think it's at least twice that and probably around 1%, which is a very high death rate compared to most other respiratory viruses and particularly flu that is here every winter.
Mukesh, Haikerwal, do we have a view, any information yet, any strong information yet about how much of a risk asymptomatic spreaders are at this stage?
Yeah, look, I think asymptomatic spread is a major thing. Numbers around 20% are often quoted that people are asymptomatic, 20% of people will be asymptomatic and have this. So we can't run around and test them all because we don't know who they are. As Peter said, there's a limited amount of reagent to do the test. So you've got the physical capacity to do tests. There's the physical number of swabs to do the tests. Then you need reagents to make the test work. So we have a limited amount of that globally. And there's a big demand for that across the globe, as you can imagine. So we concentrate on those 80% with symptoms, or those who are asymptomatic in a high-risk exposure situation. And so asymptomatic cases is a major issue. And that's why you've got to assume everybody around you has got COVID unless proven otherwise. That's why you've got to keep your hands washed, keep your distance, wear a mask, and in the clinical setting, it should be an N95 mask. And certainly we use the shields as well.
I want to come to this issue of conspiracy theories, one that we can't ignore, and we see them on various correspondence from some viewers every week, day to day. Peter Collignon, 5G has been a really big one. What's your view when you hear people say, this is all a conspiracy about, everything from implanting microchips or seeding some kind of vaccine that's infused with its own type of virus? Just set us straight on your view as a medical professional here.
Well, I'm really not sure why people have to come up with conspiracy theories because we've got enough explanations of why we've got this virus. I mean, this virus appears to have started off in bats. Somehow it got into people and then readily changed so that it could go readily from person to person and is spread throughout the world, initially by air transport. So I'm not quite sure we have to evoke 5G or the immunisation or anything like that. This is a bad virus. We know where it came from. I don't think we need anything else to tell us it's bad. And I can't see how 5G or some conspiracy with vaccine manufacturers or anything really has got any credibility.
Mukesh Haikerwal, do you come across patients as a GP yourself who are suspicious about the origins of the virus or where it's all headed and how it's treated in the future?
Yeah, look, I think we do. Luckily, it's not that many. Most people have got good information, good reputable sources and stick with it. There are some people who, no matter what you say, will find something wrong and find these conspiracies. You're talking about flat earthers or anti-vaccination people. They will beg you or demand that you listen to them and take what they're saying seriously and give them a fair hearing. When you turn that conversation around and give them the facts and say that there is a, if you go and you see the Earth from the moon is actually round, they won't believe you. And they'll swear blind because they're blue in the face that you're wrong. And so you can't do much about those sorts of people. What you've got to do, though, is make sure the people who need to know everybody else is keep themselves safe, is get the good information, as much information as you want, like from yourselves and your networks and that are going out there, and use that information wisely. You're not going to be able to make everybody understand or want to understand. They just want to believe what they want to believe, and you can't change that. But they will not hear reason, but they want you to believe their way of thinking. And over my many years of working with some of these sorts of groups, you have no chance of turning them around. They just want you to turn around, and you've got to make sure you give good information, good facts, and keep people on the straight and narrow so that they keep well and keep their families well, keep the community safe, and make sure we can actually get rid of this virus out of our community.
Peter Collignon, I wonder if you have any advice for those viewers who do come across commentary such as that, how they deal with it, if it's a family member or a workmate. Any advice on how to tackle that in a respectful and informative way?
Well, I think first of all, you've got to actually basically listen to them, at least for, some of them. They've got a viewpoint they hold and they hold it dearly. I might say I think it's wrong, but if you do need to listen. At the end of the day, I remember with giving a talk about antibiotic resistance of all things, and vaccination being in the Haemophilus influenza vaccine, and how good that was at stopping that meningitis and stopped antibiotic resistance. And there was somebody in the audience that was really anti-vaccination of what I think is a very good vaccine. And I got quite steamed and heated about it. And then afterwards, somebody gave me some good advice. They said, look, Peter, there'll always be a few % of people who have this view, and you won't be able to change their viewpoint. Listen to them. It's the people who are indifferent and don't get around to doing things. So my view is, look, this will be a few % of the population. Providing they're not doing anything to harm others, we should just respect their views, and providing it stays as a small percentage, just move on and agree to disagree and not get too upset about it.
Mukesh Haikerwal, one of the things this crisis has brought to the fore is the way aged care is run in this country. A lot of people asking the question about how you think aged care needs to change now that we know what we do about how this virus has so badly affected aged care homes.
Look, my own personal story is when I was chairman of the AMA's Aged Care Committee for Care of the Elder People, we made magnificent changes. We saw some great changes come through the system, more staffing, better care, better connection between general practice, nursing homes, hospital services, because of the levels of funding that occur, the level of governance that happens one place to the other. Today, I don't go to aged care facilities because it's so hard to work there, because the levels of bureaucracy they have to deal with, and the fact that you can't actually get people in there to help you look after your patients when you're there. So that's my stake in the ground. I said I'm not doing it anymore. So it's of no great surprise, unfortunately, that the level of care provided didn't allow them to ramp up the level of staffing, for instance, when this thing started to happen. I say at the outset, it may be seen as a disease of older people. It's not. It's of anybody. But guess what? The older people in this country are the ones that formed this country, forged the great nation that we have, and we built this country on their backs. We owe it to them to look after them, treat them with dignity, and make sure that they get the care that they need. So there's no excuse for that. Then the way in which it's done, the way in which there's different levels of government involved, and the way in which they've been, dealt with. There's some really good examples, and that's what we should be concentrating on. In Ballarat, north of here, one of my colleagues who's a geriatrician, they saw the cases coming, they did the right thing, they moved people who had infections to a safe place to be looked after in the hospital, and made sure the people in the homes were properly looked after. And that way they reduced that whole thing from happening. All we hear is the bad stories about how things went wrong. We've actually got to use the right things that have gone well and make sure we replicate that. So properly funding the sector, making sure that you've got proper staffing levels, making sure you respect the people you're working with and that you're looking after, and their families. And the families have got to be respectful of the aged care people working there, because they're working extraordinarily hard with very difficult cases, and they need some support, not constantly looking around over their shoulder. Bad stuff's happened. We know that. That's why we've got a Royal Commission going in there. And we've got reports coming out of that Royal Commission. But all of that was ignored in this COVID process, and the way in which things have been dealt with here in Victoria. And I can see places, I'm talking to you in my area and around my area, that have been really sadly disrespecting older people, leave them without food and water for 7 days, not sitting in their own excrement because they haven't been cleaned, because they sent all the workers home and nobody was there to look after them. This is not acceptable.
All right, in the last 5 minutes we've got, I've got to race through a couple more questions. Professor Collignon, Erica is one of the people asking about what we know about reinfection rates in Australia and reports of short-term immunity only being offered for those who have been infected and recovered.
Well, the good news so far is there's really not a lot of evidence for reinfection. That can occur with any infection, but this one, it seems to be low. Some of the antibody studies that have been done have shown that the antibodies fall off fairly rapidly, but whether that means you won't have long-lasting protection, we don't know. There was a large study done in Korea that looked at people with the virus and still excreting the virus later. All it appeared to be was their same virus rather than reinfection, because that was a concern. So I think the consensus at the moment is reinfection, at least into 6 months after, into this pandemic, appears to be very uncommon. Not that it can't occur, but it's very uncommon. And most people seem to have immunity at least for 6 months and presumably at least a year after their initial infection.
Dr. Haikerwal, Kristen asks what the progress is on searching for a vaccine, and Mindy asks, in addendum to that, what if there's no vaccine?
The progress is these things take time. There are multiple preparations in multiple countries that are now going in trials, but to get from that trial stage to proof, to manufacture, to being able to administer it, can take anything up to 18 months. So yes, there may be a vaccine coming. It could be fast-tracked, who knows? But at this stage, it's a way off. Yes, I think it's a very live issue that we may get a situation where there is no vaccine. We have no vaccine for TB. It's been with us for generations. We have no vaccine for hepatitis. We actually have no hepatitis C vaccination. We've actually got treatment for it. So we may be looking at treatment rather than vaccination. We didn't get vaccines for the original SARS or the MERS. So unfortunately, it may not happen. But there are other things that can happen, and treatment may well be part of that. And I think that's what we have to hope for. I mean, there is hope there. Elimination is hope. Treatment is hope. Our lockdown, we certainly hope, will clear the situation so we almost eliminate or do eliminate it from our Victorian community and our Australian community. But yes, there may not be a vaccine, but there will be treatments, I hope.
Professor Collignon, I want to come back to this question of spread, because I see a number of people asking this question about air conditioning in shopping centres, turning the heat on in the car, fans being used in a room. How much is air circulation an issue in spreading those droplets?
Well, I think it is a problem when you're a poorly ventilated place. Most of the spread occurs indoors, particularly where you've got air conditioning or heating, and that can have something to do with low humidity as well. In your own car, if you're with your people who live in the same household, I can't see it makes any difference. I think it does make a difference if you're downwind of somebody who's got an infection. Droplets usually only go about 1 metre or 1.5 metres, but if you're downstream of a fan of somebody who's coughing and spluttering, you could get it 2 or 3 metres away. So being indoors is a risk. Now in winter, that's a bit difficult. And I think in the US, the reason they're probably getting more infections in the southern states, it's so hot, they're inside together. And in winter, you can't go outside in Chicago without freezing, so you're inside, so to speak. So we need to actually have good ventilation. Outdoors is much safer than indoors. Do that as much as possible. And be careful where you sit in relation to other people. And whatever you do, don't be in crowded indoor places.
Peter Collignon, a final question to you before we come to you, Mukesh Haikerwal, on this question as well. Where do you see Australia in 3 months from now? Danny Silvio asks that question, and it's a question I think that's on the mind of a lot of Australians.
Well, I guess some of this is hope as well as maybe science. I mean, my hope is that New South Wales will control what's happened there, and we might have a little splatters of infection, but we won't have anything like Victoria. I think Victoria will get control of their numbers, but they'll still have cases even 2 or 3 months from now because there's so many at the moment, and it takes a while for them all to come down. But I would think in 3 months' time, probably both because the weather's a bit better and viruses don't spread quite as well in summer or late spring as they do in winter, we will see less numbers than we've got now.
Mukesh Haikerwal?
Yeah, I mean, mine is very much the hope. Living where we are now with a curfew, with what's called fourth level lockdown, with industry shutting down, and everyone being confined to their homes pretty much. The hope is we get out of this. The hope is we get some kind of elimination. The hope is that the effort that we're putting in pays off. and in 3 months' time, that's coming up towards the Melbourne Cup. I'm not sure we'll get the Melbourne Cup running, but we'll certainly get some opening up of our normal open spaces and being able to get out more. And by that stage, we'll have much better information and better knowledge about how to deal with this virus, so that others in other parts of our country know and can learn from what we're doing, and that we're in a much better, safer place as people, knowledgeable of how we can manage our own wellness, reduce infection spread amongst our family, friends, and the rest of our community, and that we will, going into the Christmas period and New Year, hopefully see a new dawn and a much better place to be and live and be happier and more content. At the moment, there's an awful lot of discontent, upset, and mental illness is unfortunately on the rise. But ultimately, I think we'll be in a much better place because of the effort that all of our Victorian people are putting in right here, right now, every single day. It's hard, but we're doing it, and we'll win.
I like your optimism. Dr. Mukesh, Haikerwal, Professor Peter Collignon, I know you've both been flat out at this time, so we really appreciate you joining us on this live stream. Thank you so much.
Thank you.
Thank you.
And thank you to our viewers as well for sending in your questions and keeping in touch during the last few months. Please keep sending us your questions via Facebook, YouTube, email, social media and the ABC News website, of course. Thanks for your company. We'll see you again same time next week.